Hello, today I'm going to be talking about imaging of the menisci. Meniscal tears are one of the most common knee injuries and are usually traumatic or degenerative in etiology. Meniscal disruption leads to the uneven loading of articular cartilage and premature osteoarthritis. MRI is an accurate and non-invasive way of evaluating meniscal tears and can be extremely beneficial in preoperative planning. Most standard knee protocols are comprised of a mix of fat-sensitive and fluid-sensitive sequences acquired in the sagittal, coronal, and axial imaging planes. In the fat-sensitive sequences, the subcutaneous fat, as well as the fat within the bone marrow, is bright, and you can see that this highlights the anatomy. In the fluid-sensitive sequences, the signal intensity from the subcutaneous fat as well as the fat within the marrow is suppressed, and fluid is bright, and this highlights pathology. Knees can be scanned on a 3 Tesla or 1.5 Tesla MRI scanner using a dedicated knee or extremity coil, and the patient can usually be on and off the table within 15 to 20 minutes. So in the next 20 minutes, I'm going to review meniscal anatomy and some of the common variants. We'll discuss the function of the menisci, describe the classification of meniscal tears, and to look at some common examples on MRI. The menisci are C-shaped fibrocartilaginous structures lying between the femoral condyles and the tibial plateaus. If you look at them in cross-section, they're wedge-shaped with a thicker peripheral portion and a tapered free edge, and they normally measure between 7 and 10 millimeters in width. When we look at the structure of the menisci, the peripheral third is composed of circumferential type 1 collagen bundles, and these are important to resist hoop stresses and help to absorb axial loads placed on the knee. We also have these thin radial tie fibers, and these provide structural support and help resist meniscal extrusion. You also have a vascularity in the peripheral 15 to 20% of the meniscus, and so if you have a tear within the peripheral portion of the meniscus, these can go on to heal spontaneously, whereas when you have a tear in the avascular portion of the meniscus, these are more likely to need operative intervention. The menisci function as shock absorbers and absorb between 40 and 60% of the body weight in the erect position. If we didn't have the menisci in the knee and we apply an axial load, all of the forces are transmitted across the contact points, providing great forces on the articular surfaces. However, if we put the menisci in there, they ensure an even distribution of axial load via the circumferential or hoop stress. The menisci also play an important role in joint stability and can help distribute synovial fluid within the joint. Each meniscus is divided into thirds, the anterior horn, body, and posterior horn, and each meniscus is attached to the tibial eminence by the anterior and posterior roots. As we can see in the diagram, the anterior root of the lateral meniscus blends closely with the distal fibers of the ACL. The medial meniscus is larger in diameter than the lateral meniscus. It's somewhat C-shaped and increases in width from anterior to posterior. It is also less mobile than the lateral meniscus, as it's attached to the deep fibers of the medial collateral ligament as well as the medial capsule. The lateral meniscus is of smaller diameter and is circular in shape. It has a uniform width from anterior to posterior and is more mobile. The anterior root blends closely with the distal fibers of the ACL, and the posterior root can blend with the anterior and posterior meniscofemoral ligaments. These ligaments arise anterior and posteriorly. They go from the posterior root of the lateral meniscus and pass on either side of the PCL to the medial intercondylar notch. We also have another ligamentous structure anteriorly, and this is the transverse ligament, which bridges the anterior horns of the medial and lateral menisci. If we look at the cross-section of the menisci on sagittal imaging, if we go through the body of the medial meniscus, we will see a standard bow tie appearance. And as we look at slices more centrally, you can see that the posterior horn of the medial meniscus is twice as big as the anterior horn. If we then look at it in coronal section, again, we should see this wedge-shaped structure. Here we can see a sagittal slice through the peripheral portion of the meniscus, and you can see a standard bow tie appearance. If we then move more centrally, you can see that the posterior horn is twice as big as the anterior horn. If you're not sure whether you're looking in the medial or lateral compartment of the knee, if you see a structure that looks somewhat like a golf tee with a golf ball on top, this is the medial side, and I think of my golf game as being remedial, and that helps remember. If we then look through the lateral meniscus and we take a sagittal slice through the body, again we're going to see a bow tie appearance, and as we pass more centrally, you'll see that the anterior and posterior horns of the lateral meniscus are of the same size. Again, when we look on the coronal slices, you're going to see a wedge-shaped structure. Here we can see a slice through the peripheral portion of the lateral meniscus, and you can see the standard bow tie appearance. And as we move more centrally, you can see that the anterior and posterior horn are of the same size. In this, you can see anatomic landmarks that tell you that it's the lateral portion of the knee, because you can see the fibular head as well as the popliteus tendon. But if you look at the shape of the lateral tibial plateau, this has been likened to the shape of a gun barrel. A normal variant that's quite commonly encountered is discoid meniscus, and this is more common in the lateral meniscus than the medial, and it can either be partial or complete. When we look through the peripheral portion of the discoid meniscus, again we're going to see the normal bow tie appearance, but as you pass more centrally, you'll continue to see bow ties. On the coronal image, you'll see meniscal tissue extending to the towards the intercondylar notch, and a discoid meniscus has a transverse dimension of greater than 13 millimeters. Here we see a typical example where you can see meniscal tissue extending towards the intercondylar notch, clearly measuring more than 1.3 centimeters in transverse dimension. And here, when we're looking at a central slice, a sagittal slice, again, you're going to see bow tie appearance rather than the separate anterior and posterior horns. One of the other slices I like to look at is the posterior slice that includes the PCL insertion, and you can see the posterior horns of the medial and lateral menisci, and you should be able to follow the roots all the way to the PCL insertion. Just a couple of pitfalls to be aware of. We're on the lateral side. If we're following the sagittal slice towards the intercondylar notch, you can see that there's some abnormal signal appearing in the anterior horn, quite tempting to think that that could be a meniscal tear. However, when you look at adjacent slices, you can see two structures separating from each other, and these are the transverse ligament and the anterior root of the lateral meniscus. On the axial image, you can see a hypertrophied transverse ligament, and you can certainly appreciate why you had that speckled or striated appearance to the anterior horn of the lateral meniscus. If we then direct our attention posteriorly, you can see what looks like linear abnormality in the posterior horn of the lateral meniscus. But as we go through the intercondylar notch, again you can see this little ligamentous structure separating out from the posterior horn of the lateral meniscus, passing posterior to the posterior cruciate ligament, and this is the meniscofemoral ligament of Risberg. We have anterior and posterior meniscofemoral ligaments of Humphrey and Risberg, and these can both be seen in up to 37% of knees. Here we can see the anterior and posterior meniscofemoral ligaments. H comes before W alphabetically, and on the coronal image we can see the meniscofemoral ligament arising from the posterior horn of the lateral meniscus, inserting into the medial intercondylar notch. Here we have a low signal intensity structure anterior to the PCL, quite tempting to wonder if that could be a small meniscal flap. But when we look on the axial image, you can see that this ligamentous structure comes from the posterior horn of the lateral meniscus, passes anterior to the posterior cruciate ligament, and inserts into the medial intercondylar notch, characteristic of the meniscofemoral ligaments of Humphrey. Next, we'll consider meniscal tears. It's quite common to see some degenerative signal within the menisci, particularly as we age. The normal meniscus should be of uniformly low signal intensity, as in this example. We can see a small amount of linear high signal along the periphery of the meniscus, and that corresponds to normal vasculature and may be slightly more prominent in younger knees. In grade 1 signal abnormality, you can see a small focus of increased signal within the peripheral portion of the meniscus, and this corresponds to early degenerative change. In grade 2 signal, you'll see more extensive signal abnormality, and this has been subdivided into A, B, and C. In grade 2A signal, you'll see linear signal extending into the meniscus but not extending to an edge, as in this example. In grade 2B signal, you'll see vague signal abnormality, perhaps extending to the articular surface on at least one image. Here you can see some degenerative signal, and you can see the linear signal meandering but not clearly breaching the inferior articular surface. Grade 2C lesion, you get more globular high signal within the meniscus, as in this example, and these are quite commonly associated with meniscal tears. In grade 3 signal abnormality, you'll see linear signal clearly extending to an articular surface. Here we can see fluid signal intensity extending to the superior articular surface, and this corresponds to a definite meniscal tear. Meniscal tears can be classified depending on the orientation of the signal abnormality. Horizontal tears have linear signal running parallel to the tibial plateau, whereas vertical tear, the tear runs perpendicular to the tibial plateau, and this can either be oriented longitudinally or radially or obliquely, the so-called Parrot beak tear. In a complex meniscus, you have a combination of horizontal, radial, or longitudinal signal. And in a complex displaced tear, you may have a small flap of meniscus that's displaced, as in this example, or you can have a more substantial displaced fragment, either a bucket handle tear or a flipped meniscus. If we look at the horizontal meniscal tears, as I said, the tear runs parallel to the tibial plateau and extends either to an articular surface or the free edge of the meniscus, essentially dividing the meniscus into superior and inferior halves. These are often degenerative in nature, and the prevalence of these increases with age. We'll see linear signal extending to the free edge in this example, and this may or may not be associated with a parameniscal cyst. Here we see an example where you can clearly see that there's signal intensity extending to the superior articular surface in the body of the lateral meniscus with a small associated parameniscal cyst. It's good to use the two-slice touch rule. This refers to increased intrasubstance signal that unequivocally contacts an articular surface on at least 2 consecutive images, and this has a very high positive predictive value for the diagnosis of medial or lateral meniscal tears. Other signs that you can look for that will increase your diagnostic confidence include the presence of bone marrow edema. In this example, we can see some signal abnormality extending to the inferior articular surface in the posterior horn of the medial meniscus. But you can see this characteristic linear subchondral bone marrow edema subjacent to the signal abnormality in the meniscus, and this measures 5 millimeters or less in depth, and this has a high association with the presence of meniscal tears. Again, here we can see signal that appears to extend to an articular surface, but again you can see this characteristic subchondral linear bone marrow edema. Other things that you can look for include the presence of a parameniscal cyst. Here we can see signal abnormality again that appears to extend to the inferior articular surface, but we can see a small focus of high signal corresponding to the development of a parameniscal cyst. And when we look on the corresponding coronal image, you can see linear signal abnormality throughout the posterior horn of the medial meniscus with this large lobulated adjacent parameniscal cyst extending past the joint capsule. Longitudinal vertical meniscal tears. These tears run perpendicular to the tibial plateau as well as parallel to the longitudinal axis of the meniscus. These are usually seen in younger patients and are usually post-traumatic in etiology. They're characteristically peripheral and involve the posterior horns of the medial or lateral menisci and have a high association with anterior cruciate ligament tears. In this example, we can see that there's linear signal through the peripheral portion in the posterior horn of the medial meniscus, characteristic of a longitudinal vertical tear. When we look on the axial images, you can see the signal abnormality extending throughout the posterior horn. Radial tears are also vertical tears, and in this they are oriented perpendicular to the longitudinal axis of the meniscus, essentially transecting the longitudinal collagen bundles. This obviously will disrupt the hoop strength of the meniscus and can lead to meniscal extrusion. If we take a slice here, you can see the normal triangular wedge shape of the meniscus, but as we pass through the tear, you're going to see truncation of the meniscus. These are extremely common at the junction of the anterior horn and body of the lateral meniscus, or in the posterior horn of the medial meniscus. Here we see a typical example of a small radial tear, where you can see a small cleft at the junction of the anterior horn and body of the lateral meniscus. When we look on additional planes, we can see that there's some subtle truncation of the free edge of the lateral meniscus, and you can see this small cleft corresponding to a small radial tear. Here we can see a more substantial radial tear along the posterior horn and root of the lateral meniscus. On the sagittal image, we can see that there's marked truncation in the posterior horn. And when we look on the axial images, you can see that there's a near full thickness radial tear at the posterior horn and root junction. Parrot beak tears are more obliquely oriented, as you can see in this example, and it's been likened to the shape of a parrot beak. If we take a slice through the edge of the tear, you'll see the standard little truncation of the free edge, but as you pass through the tear, you'll see the signal abnormality migrating through the substance of the meniscus, and this has been called the migrating cleft sign. If we look at an example, here we can see the significant truncation of the posterior horn of the lateral meniscus in a patient who has an ACL tear with characteristic kissing contusions on the lateral femoral condyle and posterior lateral tibial plateau. Here we can see the truncated meniscus, and as we pass on adjacent slices, you can see the migrating cleft sign extending through the meniscus. When we look on the axial image, you can see the obliquely oriented parrot beak tear. What things will increase your suspicion for an underlying meniscal tear? Another thing you can look for is meniscal extrusion. In this example, you can see that the peripheral portion of the meniscus projects more than 3 millimeters from the edge of the medial tibial plateau. And if you see meniscal extrusion, you need to look very hard for a tear. And here we can see a large tear in the posterior root of the medial meniscus. This is a complex radial tear in the posterior horn of the medial meniscus. You can see that it has both vertical and horizontal components. Here we can see a fairly substantial radial component, and you can see that there's some signal abnormality in the medial femoral condyle. On coronal imaging, we can see a large radial tear in the posterior horn, and this has resulted in meniscal extrusion. When we pass through the medial femoral condyle, you can see this curvilinear low signal intensity compatible with a subchondral insufficiency fracture, and you can see that there's corresponding bone marrow edema. So essentially, you've lost the shock absorption, all of the forces are transmitted across the articular surfaces, and this has led to the development of a subchondral insufficiency fracture. These are most commonly located in the medial femoral condyle, but you can see them elsewhere in the knee. Displaced meniscal tears are also quite common. So here we can see a flap of meniscus that is displaced. These are most common in the medial meniscus, and the patient tends to present with mechanical obstruction or locking. If we look in the posterior horn of the medial meniscus, we can see that there's a large chunk of the meniscus missing. We want to look in the different imaging planes to see if we can locate where this piece of meniscus has gone. And here we can see a large flap displaced towards the intercondylar notch. Small flaps are very common in the medial meniscus at the junction of the body and posterior horn. You can see a small flap here displaced into the inframedial gutter. These are extremely difficult to see at arthroscopy. Therefore, it's very important for us to identify these and indicate in our reports so that when the patient does undergo arthroscopy, the surgeon knows to introduce a hook into the inframedial gutter to deliver the flap so that it can be resected. Flaps can also be quite large. Here we can see the anterior and posterior horn of the medial meniscus are of the same size, so we know that this is smaller than we would normally expect, so we want to look for a displaced flap. Here we can see the body is also markedly truncated, and we look on the adjacent slices and you can see that there's a large flap of meniscal tissue displaced into the inframedial gutter. These displaced flaps can also be seen in the lateral meniscus. Here we can see that there's irregularity and diminution of the body of the lateral meniscus, and we look for the adjacent slices to see if we can see a displaced flap, and here we have a large flap displaced posteriorly towards the popliteal tendon sheath. When we look on the sagittal images, you can see the extent of the meniscal tissue that is missing, and the meniscal tissue is displaced posteriorly, lying adjacent to the popliteus tendon in this example. Other tears that we can encounter are bucket handle tears, where you get a longitudinal vertical tear and a large flap displaces into the intercondylar notch. These are most commonly seen in the medial meniscus, but can also occur in the lateral meniscus. So here we can see that there's marked truncation of the body of the medial meniscus, and then we look into the intercondylar notch, and you can see a large displaced meniscal fragment. When we look on the sagittal images, you can see the extent of the meniscal fragment that's displaced into the notch, and you can see that this looks of similar signal intensity and orientation to the PCL, and this has been termed the double PCL sign. Flipped meniscus can also occur. Again, you get a longitudinal vertical tear, and a piece or even the entire posterior horn of the lateral meniscus flips anteriorly and lies adjacent to the anterior horn. Here we can see that essentially the whole posterior horn of the lateral meniscus is displaced anteriorly, and you've got the double anterior horn sign. Again, you can follow these meniscal fragments towards the intercondylar notch, so essentially a variant of a bucket handle tear. Here we see another example of a flipped meniscus. Again, the posterior horn of the lateral meniscus is displaced anteriorly. You can see the double anterior horn sign. And on the axial images, here we can see the native anterior horn, and you can see just posterior to this is the flipped over posterior horn of the lateral meniscus. So how accurate is MRI in the diagnosis of meniscal tears? You can see that if the patient doesn't have an associated tear of their anterior cruciate ligament, you have a high sensitivity of 97% for the medial meniscus and 94% for the lateral meniscus. However, if the patient also has an associated acute ACL tear, you can see that the sensitivity drops off, particularly for the lateral meniscus. Maybe that the trauma mechanisms results in meniscal tears that are more difficult to identify on MRI, and these tears are most common in the posterior horn, in the peripheral portion of the meniscus, or within the meniscal roots. Meniscal tears are more commonly missed in the lateral meniscus, and this is likely due to the complex anatomy around the popliteus tendon sheath, as well as the posterior root. However, not all of these tears are going to be clinically significant, particularly if they're in the periphery of the meniscus. Here we see a patient with the characteristic kissing contusions, in a patient characteristic of an ACL tear. If we look in the posterior horn of the lateral meniscus, you can start to see some vertically oriented signal compatible with a vertical longitudinal tear. On the axial images, again, you can see that tear within the peripheral portion of the posterior horn of the lateral meniscus. Here we have an example of a peripheral tear where you can see linear signal abnormality extending to the superior articular surface in the posterior horn of the lateral meniscus. You can see that's a fluid signal intensity, and again the patient has characteristic kissing contusions compatible with an underlying anterior cruciate ligament tear. Peripheral tears can also occur in the medial meniscus. Another patient with an ACL tear, and you can see linear signal abnormality extending to the inferior articular surface peripherally, and you can see that there's a bone marrow contusion within the medial femoral condyle. So meniscal tears are extremely common and can lead to premature osteoarthritis. MRI is the best imaging modality to non-invasively diagnose meniscal tears, and an accurate description of the meniscal tear is key for preoperative planning. and it's important to be aware of some of the meniscal variants as well as some of the potential pitfalls. Thank you.